Good afternoon. I want to thank you for taking the time from your busy schedules to join us for today's webinar entitled The Parent is Your Patient Too, Making the Case for Intimate Partner Violence Advocacy in the Pediatric Healthcare Setting. If you're a physician, nurse, or social worker joining us today, there is an opportunity to gain credit for this webinar. Additional information regarding continuing education units was provided in the reminder email sent from WebEx at 10 a.m. this morning. If you're eligible to receive these credits, please make sure to complete the online survey that will pop up when we end the webinar today. None of the presenters have anything to disclose. If you have questions or experience any difficulties in obtaining your continuing education, please send an email to Kim Sloth at the email listed here. This webinar is being hosted by the Violence Prevention Initiative at the Children's Hospital of Philadelphia. And my name is Rachel Myers. I'm a research scientist within the Center for Injury Research and Prevention here at CHOP. The goal for today's webinar is to address the issue of intimate partner violence within the pediatric healthcare setting. And there's several objectives for today's webinar. First, to recognize research links between intimate partner violence, or IPV, and public and pediatric health. To be able to list barriers to providing IPV medical advocacy in the pediatric and medical setting. To identify strategies for successfully integrating IPV into most medical settings. And to create action steps for partnering with participants' local pediatric healthcare providers. Healthcare providers serve as important partners and also trusted sources of information as parents navigate the joys and challenges of raising healthy children. While intimate partner or domestic violence is commonly thought of as a private personal matter, we know that all too often children witness such violence in their homes, as recent national data suggests that more than 1 in 4 youth and adolescents report having witnessed violence between their caregivers. Supporting parents in accessing resources and enhancing safety for the entire family is one way that healthcare providers can begin to address this exposure and prevent adverse outcomes. Implementing routine inquiry regarding IPV among caregivers of our patients is an important way in which pediatric healthcare institutions can work to overcome stigma related to IPV and to support families in accessing the right resources at the right time. However, such screening in the pediatric setting is not without its challenges. The sensitive and confidential nature of IPV disclosure, discomfort among providers in responding to such disclosures, and limited knowledge of available resources all may present barriers in clinical practice. Through our exciting partnership with Lutheran Settlement House and their Stop IPV program, about which you will soon learn more, we have established a strong partnership that has overcome these barriers and allowed us to establish and enhance our institution's efforts to address IPV as a pediatric healthcare institution. Before I introduce our speakers today, I'd like to address a few housekeeping items with you. First, if you're having any technical difficulties, please double check your confirmation emails. The latest one was sent around 10 a.m. this morning. In the emails, you will find links to join the meeting and to download WebEx Event Manager for first-time users. You should hear the audio through your computer speakers. There's not a call-in phone number available for audio. At this point, we will not be able to help you with technical issues. If you have questions for the presenters as we go along today, and we do encourage your questions, please type them into the chat text box at the bottom of your screen and direct them to our host, Lindsay Mitros. There will be opportunities to ask questions throughout the presentation, and we'll save time at the end today for questions and answers as well. Because of the large group joining us, it's not possible to open up the lines for audio or verbal questions. Also, other participants will not be able to view the questions or comments you submit. From previous webinar feedback, we've learned that this can be distracting for participants. And lastly, this webinar is being recorded and will be posted on our website, chop.edu/violence, within the next week. So today's participants, we have close to over 100 people registered for today's webinar, speaking to the interest and concern in addressing the problem of intimate partner violence among families. Among our participants, we see people from many disciplines, including medicine, nursing, social work, health administration, education, and health educators, as well as many locations across the country: Texas, Vermont, Virginia, Louisiana, and Wisconsin. If we're not describing your role or location, please text us in the chat text box and let us know. So now it is time to introduce our speakers. So today, joining us will be Dr. Ashlee Murray, an attending physician in the emergency department here at CHOP and a fellow of CHOP's Violence Prevention Initiative. Marcella Nyachogo is the Assistant Director of the Bilingual Domestic Violence Program at Lutheran Settlement House. Lutheran Settlement House is a nonprofit, community-based organization committed to serving children, adults, and families living in Philadelphia. India Azzinaro is a medical advocacy supervisor at Lutheran Settlement House and at CHOP, and she's also a fellow of our Violence Prevention Initiative here. And so without further ado, I will turn the mic over to India.
Good afternoon, everybody. I want to thank Rachel and all of our CHOP friends for helping us host and facilitate this webinar. We're all really excited. And also echo her welcome to our webinar titled "The Parent is Your Patient Too." We're so honored that you all have taken your lunchtime to be with us this afternoon. I'm particularly excited to be one of your facilitators because I'm coming to you as an advocate on behalf of parents in the pediatric setting. I've had firsthand experience mending the fences, encouraging folks to see IPV as a pediatric issue, and offering providers and professionals the resources that they need or ask for to help navigate in between the two worlds. You have two pictures in front of you. I like to offer up folks a visual of what our team looks like. We're bright, bubbly, and fun. The photo you have to your right is of our current team at the moment with our partners, with our advocates who are providing support to our Philadelphia partners. From left to right, we have our advocate, Anna, who's providing support to Einstein. Then we have Julia, who's at St. Chris, myself, who's in the middle, Ashlee, next to me, who's providing support to CareBots, Jessica, who's at CHOP Maine, and lastly, Akia, who's providing support to ARIA Frankfurt and Torresdale hospitals. Now that I've given the briefest introduction ever, we are eager to learn who we have joining us this afternoon. Please take a moment to type your role and agency into the comment box. While you guys are doing that, we also want to thank you for all of your pre-registration answers and responses. We asked you to share with us any challenges or barriers you faced when addressing intimate partner violence in the pediatric setting or a health center in general. I believe it would be valuable for the rest of the folks to hear what the larger group deemed to be some of those challenges. I imagine learning that the next person is here today in search of ideas and solutions similar to your own would be helpful. I'm going to share some of those pre-registration responses now. Please type in any other challenges or issues that you'd like to have answered today so we can make sure we address all of them before the end of our webinar. So some of those pre-registration responses, we took a toll of all of the responses and tried to compile them into a pretty condensed list. So far, we've jotted down that folks are interested in learning how to overcome creating a safe environment for disclosure, how to overcome the distrust of social workers or social workers within their network. Folks said that barriers have been the time that it takes to screen. We hear that a lot from our hospital partners, that providers and doctors only have a limited amount of time to go through a laundry list of other equally important issues. So sometimes addressing IPV kind of takes the back burner. We also jotted down that folks want to learn how to separate caregivers and also overcome medical record confidentiality issues. Okay, so we have some folks from the emergency department, forensic programs, social workers, DPI folks, adolescent care management, Okay, thank you. Please feel free to fill in also as you go along. All right, so I have the pleasure of speaking about Laura Fernandez. Laura was a very dear client of mine. She was referred to me through one of our hospital partners back in 2012. Her children had been patients at the clinic for years, but after some of those years, she finally did screening happen from her provider. Before screening, she never said a word about the abuse that they lived with to any of her providers and rarely her family or friends. Laura told me that she felt embarrassed to open up, and how could the doctor's office really help her anyway if she's an adult and her children are their patients? She often said to me, if they didn't start asking me about IPV when they did, you and I would have never met. When I met Laura, she was nearly homeless and fighting for custody for her children. Laura is not the only patient who this has or who this will happen to. There was an article published in 2002 in the Court Review that concluded parents are less likely to disclose IPV unless they are asked directly. Parents want to be asked by their providers, by their children's providers. In 2014, I nominated Laura for a Women of Courage Award, and she won. I wasn't surprised at all. Laura's story speaks to her bravery and resilience. We have Laura's video up on our website at www.lutheransettlement.org. However, for the sake of time, we aren't able to show the video, but please check it out when you can. I do want to share with you something that stood out from her video, and I think you'll agree that it's powerful. Laura shared in her video that she said her kids see her as strong, that her daughter actually described her as a grizzly bear, because grizzly bears are fierce and they're good mothers. Laura says every day she strives to live up to that daily. Laura is an example of when community partnerships work. It hasn't been easy to shift the focus to pediatrics, that it's important to prioritize cases like Laura's relationship when there were no immediate or acute issues with her children. Our argument for being in the pediatric setting should be, and yours should also be, that kids are indeed impacted by IPV. And you'll hear about those later. So intimate partner violence, you may also hear us throughout this webinar refer to it as domestic violence. Either way, either term that we use, either term that you listening in feel comfortable using, in a nutshell, we want to explain it as being this. We want to explain it as being a pattern of abusive and controlling tactics that one partner uses to gain power and control over another person. IPV and domestic violence is not an isolated incident. It is indeed a pattern of those coercive and controlling behaviors. The power and control wheel is one of my personal favorite education tools for professionals as well as clients. It is a particularly helpful tool in understanding the overall pattern of abusive and violent behaviors, which are used by an abusive and controlling person to establish and maintain power and control. Very often, one or more violent incidents are accompanied by an array of these other types of abuse that you'll see in this wheel. They are less easily identified, yet firmly established as a pattern of intimidation and control. For Laura, for example, her husband used more intimidation, put-downs, financial control, and other quote-unquote less obvious tactics than he actually ever used physical abuse. Minimal or lack of physical or sexual abuse, survivors feel less validated or believed. I do want to share that Laura at this moment has decided to take her advocacy and her bravery to the next level and identify places throughout the city where she feels like she can be an impact on other people's lives, and she's currently going through some pretty phenomenal and intense training right now to learn how to be an advocate to speak out for other survivors and victims of domestic violence.
Thank you, India. We just want to remind folks and invite you to write any questions you may have on the information just presented, or again throughout the webinar, in the chat box that appears on your screen. So moving ahead, I'll now turn the microphone over to Marcella, who will talk about Lutheran Settlement House's Stop IPV program.
Hi, everyone. Again, thank you so much for spending this time with us today. We're excited to talk about this issue with a lot of folks who obviously care about it by nature of signing up for the webinar. So we wanted to start just by giving you a little bit of background on our program so that you kind of understand the context under which we sort of try to tackle this issue along with CHOP and our other partners. So the STOP IPV program is an acronym. We're social workers, and social workers love an acronym. So STOP actually stands for Screening, Training, Operational Response, and Policy and Program Review. And those are really the different ways that we try to tackle IPV with our hospital partners. And I'll just go through each of those. Screening, so what we do with all of our partner hospitals is try to figure out how we can make screening for IPV work for their setting, for their patient population. And so screening looks different at every single one of our hospital partners, and we recognize that screening can only happen if it's realistic and practical for the folks who are working in that medical setting every day. And Ashlee's going to talk to us about the really innovative way that, that CHOP solves a lot of their barriers that were specific for their population. We also know that screening is kind of a hallmark of our program because it has become recommended by many medical institutions. It's become really a standard of practice that we should all be screening our patients and families for intimate partner violence. It's really being recognized as a public health issue finally, and so screening is definitely something that is recommended, if not required, for most medical sites at this point. Training and outreach, again, we know that screening can't happen if people are not equipped with the information, knowledge, and most importantly, comfort about how to address this. So really offering webinars like this, as well as in-person trainings at all of our hospital partnerships, allow that screening to take place so we can even figure out who are the folks who are affected by this issue. Operational response. In our partner hospitals, we have the benefit of being able to provide immediate on-site support for any individual who is identified as an IPV victim, either through the screening process or through their own disclosure to anyone in that medical setting. And so, you know, places that don't have a partnership with us, we do absolutely work with them to try to figure out what their operational response is, whether that be having a designated champion team there of folks who are able to respond best. We definitely have the most success in having an advocate on site to provide that operational response, but we also train any medical site who's interested in figuring out what that response can be, because we know that that's another major barrier to screening, is kind of not knowing what to do when a disclosure does occur. And then lastly, and this is sort of the most macro part of our work, we really try to turn each of our hospital partners into safe havens for survivors and their families. And oftentimes that looks like looking at the big picture. So we do policy and program review. We try to make sure that visually and in protocol and practice, every hospital feels like a safe place for survivors. And we do that alongside our task force and champion partners, which are kind of designated stakeholders within each of our partner hospitals who we work with to try to make those system changes. So again, we know IPV is a very complicated issue, and our program really tries to address it on these multiple levels within our partner institutions. And we have been successful in kind of expanding our program over the years through our match funding model, which is kind of an innovative way that we try to leverage funding and support to be able to be in as many hospitals and health settings as we can. So all of our partner hospitals contribute financially to the program, to having an advocate there, again, because it really does mean putting one of our advocates on site at that hospital for 4 days a week. And then what we do once we find that there's hospital interest is we leverage, as a nonprofit which offers lots of different services, Lutheran Settlement House does have a lot of foundation connections, and so we leverage that hospital match with a foundation match to be able to try to create as much sustainability as we can so that we can be present in as many hospitals as will have us. And so Ultimately, we're working on kind of different models of sustainability and kind of figuring out what the financial process will look like moving forward, but the match funding model has been really successful for us so far. Our current hospital partners include CHOP, of course. We have an advocate at the Karabots outpatient pediatric site and an advocate at the main site serving the ER and select other departments. We have an advocate at St. Christopher's Hospital for Children, and we have advocates at Aria Jefferson Health at the Frankfurt Hospital site and at Einstein at their Philadelphia campus. And just a little bit of an overview of kind of the scope of our services. So this is from last fiscal year. We were able to serve almost 500 patients within those partner medical settings, patients or caregivers who were impacted by intimate partner violence. So this is not even the total number of folks who were identified as survivors. It's only folks who wanted services and ultimately connected with us. So you can imagine that the number is even bigger than that. We also provided nearly 650 case consultations, and that's another service that we provide, which we kind of house under technical assistance. So a lot of times providers, once they start screening, their antenna are up, and so sometimes they'll meet with a family where maybe it's not safe to screen, or they're not able to screen, or the client or family denies that IPV is happening, but the provider has a suspicion. So what we'll do with case consultations is provide a safe space to have that provider or healthcare staff come to talk to us about some strategies for next time that family comes in, how can we get that potential victim alone so that we can screen safely? Or sometimes it looks like just letting that provider know you did exactly the right thing, and sometimes people aren't ready to disclose. And so you can see that a lot of folks in our sites really use our expertise to try to problem solve around that. And we also do a very lot of training. We know that there's always more to learn about this issue, so we go through our own training a lot, and then we make sure to share all of that and the emerging research with our partner hospitals. We also instituted evaluations for the first time over the past year, and that's been really helpful in kind of eliciting the voices of our clients to make sure that our services are kind of serving their needs. And we were really excited. These are just some snippets to hear that over 90% of our clients said that they did know more about resources available to them after meeting with our counselors. And we know that 90% of our medical partners who participate in our training know how to appropriately screen their patients post-training. And so those are just some ways that we keep tabs on ourselves to try to always be continually improving the program. Unfortunately, it took a really devastating gap in funding to realize just how important our presence is at our partner hospitals. This is a chart from tracking client referrals to our program. We, in 2014, we lost funding and had to pull out of one of our longest standing hospital partner sites. And that year, although we were still available remotely by phone or pager, referrals of survivors to our program dropped from a yearly average over the previous almost 10 years of over 200 per year to just 9 the year that we weren't physically on site at all. And so what this really tells us is that it does make a difference to have a partnership with a domestic violence provider, because people need to be able to feel like they can hand off this really difficult, complicated issue to folks who do this work every day. And so that's why we really share that. And we'll talk about strategies for creating those partnerships. Luckily, we were able to reestablish funding, and we're back in that hospital at full-time presence and back at our 200 a year referral rate. So, you know, it was a tough lesson learned, but we're back at it. And this is just a helpful visual to show kind of program growth. This is from Children's Hospital of Philadelphia. And it just goes to show you that for all of our service metrics, for our referrals, our case consultations, our trainings, every year that we're present in a medical site, those increase because more people learn about us, more people start screening, people get more comfortable. And that's really our goal, is to ultimately become part of the fabric of each of our medical institutions. So just really quickly, our Stop IPV program has a long history in Philadelphia. We started in partnership with the Institute for Safe Families, which has since disbanded, and we were under the title Children and Moms Project, or CAMP. And that was actually the first pediatric hospital-based domestic violence intervention program in the state. And so we're really proud of that. It was definitely a very innovative approach even then. And we've since changed the name because we know that, well, we've expanded to adult medical settings, and we also know that IPV can impact anyone. It's not just a mom issue or a woman's issue. And so we've done some kind of rebranding since then, but we're really proud of the roots of the program and the fact that it came out of this really dedicated group of professionals across the city through ISF who were committed to ending family violence together. So we were lucky enough to retain the CAMP program once ISF disbanded, and then we expanded from St. Christopher's Hospital, which is our very first hospital partner, to the Children's Hospital of Philadelphia Carabot Center and to Einstein's Pediatric office. Then we expanded further within CHOP to the emergency department and to our 2 adult settings. So we expanded services in Einstein outside of pediatric and now provide services hospital-wide. And just last year, we partnered with ARIA Health to provide services in their Frankfurt site. So we're now called the Stop IPV program, but we've learned very much over our 10+ years trying to address IPV within the Philadelphia context. So we like to just remind, I mean, we're really kind of preaching to the choir here because you're all here because you're interested in this, but I like to remind people of why intimate partner violence has really become this public health issue that people are very much linking with health. And that's because we know, unfortunately, that experiencing IPV is associated with a host of lifelong negative health outcomes. And these are some of the just most startling ones. So we know that it significantly increases likelihood for experiencing stroke, heart disease, asthma, as well as mood disorders like depression. And so, again, a lot of these studies were done specifically on female survivors of IPV. We know that those health outcomes are likely reflected in other survivors as well. But this is just to show that, you know, it was really previously seen as kind of a family issue, a private issue, even a social health issue. And we know that there are real physical health impacts of this issue, and that's really why we're all here to address it together. I also wanted to share, kind of in addition to the numbers, which are really startling, is just kind of some real emotional tax that experiencing IPV can take on people. So I have just 2 really quick client stories that we asked our advocates to give us some stories about kind of clients who've had really emotional impacts of IPV, and here are just 2 of them. So one of our advocates shared, I had a client who stopped our conversation to tell me that she could see her abusive partner in the corner of the room even though she knew he wasn't there. It was really scary for her. She also would jump whenever she heard a noise outside the room, saying, I know he's not here, but I'm just so afraid he's about to open that door. We had another client who was seen in one of our adult settings, and she said, her advocate said, I had a client tell me that she hadn't slept for weeks because when she closed her eyes, she felt like she was being beaten again in her dreams. When I got the referral, she had been hospitalized because of fatigue. She had been up for 6 straight days. And so again, I mean, we really, we try to paint the picture that, as India said, sometimes IPV is very cut and dry, and sometimes its impact is very difficult to observe if you're not actively having these conversations with clients. We also know another kind of big area of research around the impact of IPV is on women's reproductive health. So intimate partner violence, and there's new research, it feels, every day around this, but intimate partner violence increases a lot of risky reproductive health issues. So there are increased rates of preterm deliveries, low birth weight, also increased risk of just inconsistency with getting appropriate prenatal care. And again, because that's because when someone is being abused, they're not in control of their schedule and their ability to get the necessary medical care that they need. It's also associated with risk-taking behaviors during pregnancy, like smoking and substance abuse. And unfortunately, we know that homicide is a leading cause of death in pregnancy and postpartum. So a lot of times we'll hear our clients say that getting pregnant actually feels like it's going to protect them, and logically I can totally understand why they would feel that way. What we know and what we share with them is that unfortunately pregnancy actually almost always really increases the risk for frequency or severity of violence. And so a lot of OB offices have become very vigilant about screening and addressing this because of these impacts.
Thanks so much, Marcella. One question that came in while you were presenting, and I wonder if you might be able to speak to it, was whether there are any plans to develop partnerships with hospitals outside of Philadelphia that they could establish STOP IPV programs in their sites as well.
Definitely, yeah. Thank you for asking. You asked before I even got to pitch, so I'm excited. Yeah, we are always interested in looking for kind of how we can support other folks outside of Philadelphia in doing this work. We actually just got finished a sort of program review, and we do have different kind of tiers of program offerings that we are providing now. And one of those options is for folks who are outside, very far outside of Philadelphia, where we can't have an advocate on site with the kind of full-time partnership that we have with our current partners. We can provide training, consultation, and technical assistance to help other sites, assess where they're at as far as IPV readiness and screening, and then we can try to kind of figure out a tailored plan for getting screening and referral and partnership up and running at those sites. And so if anyone is interested in discussing that further, we would love for you to reach out and let us know how we can support you with that, because we ultimately just want every site everywhere to be screening and referring for IPV. That's definitely our ultimate goal.
Thanks so much, and we do encourage you to keep those questions coming. So next we're going to turn it back over to India, who's going to talk about adverse childhood experiences and the effect of IPV on our pediatric patients.
All righty. So now we're here to talk about why we're actually here. Intimate partner violence as it pertains to children, as it pertains to adolescents and young adults. I feel it's pretty valuable and significant to start with a conversation about ACEs, the adverse childhood experiences. ACEs is one of the largest investigations ever conducted to assess associations between childhood maltreatment and later life health and well-being, and also any potentially traumatic events that can have negative and long-lasting effects on health and well-being. These experiences that ACEs focused on range from physical, emotional, or sexual abuse, all the way to parental divorce or incarceration of a parent or of a guardian. It's not a rule anywhere that says the occurrence of some of these ACEs means that IPV is present. However, when there is IPV, sexual abuse, or other neglect, or other ACEs, then these ACEs are likely to co-occur with IPV. And we like to bring that into the conversation with providers because often, even to this day, I've been doing medical advocacy for a little over 5 years now, and some providers still ask, well, if the parent is not my patient, the child is my patient, why am I wondering, or why am I screening, or why am I asking about how what the parent is going through is impacting the child? And then I say, well, that's a really good question. I'd like to bring your attention back to the ACEs study. And I feel like that's all I really have to say. So I feel like ACEs has been a really good buddy and a help to the IPV movement in getting IPV brought into the pediatric setting. Not only does exposure to IPV and other traumas impact health outcomes, exposure to serious IPV as a child is also associated with offending as an adult. Among a sample of IPV offenders, those who had as a child seen a parent use a weapon were more likely to commit an offense involving a weapon as an adult. Many folks in the IPV realm believe firmly that IPV is indeed a learned behavior. So the significance of connecting families and children with safe and consistent, competent, and reliable support is necessary and indicative to a child bouncing back and finding balance and safety in their lives. Being an eyewitness to IPV can hurt a child experiencing the aftermath, being directly a victim of child abuse or emotional abuse, seeing injuries resulting from the abuse or being told about the violence, being physically abused are among the many other ways that children are hurt by IPV in their family. Can you guys think of any other ways that children are impacted by IPV? Feel free to add that into the comment box now. So these next few slides, when we're talking about children who witness IPV, I'm meaning children aged infancy to adolescence. Oftentimes, far too often, actually, teens are forgotten about. Teens are put into their own bubble. Teens are considered to be kind of their own group of individuals when really they also are a vulnerable population. They also are incredibly impressionable and still need resources to help support them in thriving with their development, with their social skills, and with their education. We wanted to bring these few points to you guys' attention today. Children who witness IPV have an increased risk of having developmental issues, a higher occurrence of behavioral, social, and mood disorders. Pretty much anything that threatens a person's well-being and stability is a stress. Stress impacts the body. The body begins to focus only on fighting that stress. So if you have a child or a group of children who live in homes where there is IPV or serious sexual abuse or emotional violence, that child may come off as standoffish. They may suffer from having PTSD. They may withdraw in their social life. They may at one point were pretty affluent and engaging with their peers, having extracurricular activities. However, the stress has taken over and they're only focusing on the survival of themselves or maybe thinking about what's going on at home. And it's distracting them from what's going on in school, so they can't thrive. It's pretty difficult for them. Children who witness IPV are also at greater risk for substance abuse and teen pregnancy in adolescence. So again, screening for IPV in a pediatric setting can definitely get in front of a lot of these issues, and if not, at least address them so families are aware and feel equipped to be able to respond. In 2011, this is a pretty heavy stat. In 2011, approximately 1,500 children died from abuse and neglect across the country. Younger children definitely appear to exhibit higher levels of emotional and psychological distress than older children. And we'll talk a little bit about why we say that is in the next slides to come when we talk about the building blocks of the brain. Aside from the statistics that you'll hear us share, aside from the statistics maybe that you read or have spouted at you, we want you guys to also be aware that shrouding the violence in secrecy allows this behavior to continue. Breaking the silence is a way for families to feel heard and to feel validated and to feel connected. So that can look like in your setting, posting IPV flyers, putting materials in the bathrooms, having hotline cards available, maybe having providers just asking questions, or maybe if they see something concerning or if they see some red flags exhibited, maybe saying something if not to the family, then to the provider. So then everyone is aware, and also so if it comes back to the family, it doesn't feel like they're being targeted. The language is pretty neutral and common throughout the institution or throughout the environment that they're in. Throughout our presentation, you'll see these little drawings, these pieces of artwork. These were put together by some of the children that received services at Lutheran Settlement House, and they were asked to draw what domestic violence in their home and in their family looked like. So when talking about how IPV impacts children, some folks respond better to numbers, other folks may respond better to stories or testimonials from our clients, and then we have some other folks who respond to just seeing it, just getting down to the nitty-gritty. How does this impact children? What does it look like, and what does it do to them? So the brain is forever growing. It's always trying to find the next moment to gravitate or attach to something that's interesting and exciting that can help them grow. Brains develop from the top to the bottom, from the inside out. Healthy development and mental processing depends on healthy development of the lower parts of the brain, which are most impacted during early childhood. Brain stem is where our fight, flight, or freeze instincts are held. If a child is young, the more advanced parts of the brain will not develop as fully under stress or within environments that are unable to provide safety. When we experience extreme stress, a hormone called cortisol shoots through our bodies. Cortisol constantly shoots through our brains, fundamentally altering our brain's chemistry. So that looks like children who have attachment issues to safe and reliable adult supports are more likely to respond positively to interventions and demonstrate greater resiliency. Just recently, we're really proud and happy to have brought on a child therapist because we know that parents feel really worried and concerned about how their relationship or how their abuse has impacted their children. So we've always known this. When we provide counseling, whether it's individual or group, to parents, 90% of the time it comes out like, I'm really worried about my children. So we've been able to secure some funding to hire a therapist to be able to meet with children outside of the meetings and the sessions with the parents. So it can look like a child coming into a session by themselves, or maybe if a parent is coming for counseling, the child can also meet with our child therapist and work through some of those things. Help the child feel related to, help the child feel validated, and help them make some sense of what's going on in their lives. We also know that when children are connected to or working with or have an attachment with a safe and reliable individual, that can look like a therapist, it can look like a teacher, it can look like an auntie or a neighbor up the street, children are more likely to feel safe, and their progression and their development can increase, and the outcomes of that are incredibly positive. So I talked a little bit about teens a few minutes ago. I'd like to spend a little bit more time talking about them here, because at the pediatric clinic that I work at, we have a really robust family planning program. And a lot of the referrals that I've gotten over the years have come from teens. And providers feel like with support being available on site for them, they don't have to be the ones to respond. They don't always have to be the ones to safety plan, and they don't have to be the ones to follow the teens, or maybe even feel like something that they've done or they missed the mark with the teenager, because support is available for them upon screening. A significant number of teens make up the patient population at the pediatric care setting I work at. They're the forgotten ones. So you'll see that 1 in 6 teens treated in the ER have reported having a history of dating violence. And there's an early onset as early as 11 years old. I had a parent come to me one day and she said, you know, I'm really worried. I feel like my child is in a relationship that resembles mine. And after sitting with that mom for a little bit and letting her be in her feelings, I asked her, so what makes you think that your child is in a relationship similar? She said, I'm seeing a lot of the same isolation. I'm seeing her self-esteem go down. She's digressing in her schoolwork, and I just feel like she's not the same. So I asked, you know, how old is your child? And she said she's only 12 years old. So for me, it was a bit alarming, absolutely alarming, and, you know, heartbreaking for the mom. So I was able to share some information with her about, you know, how domestic violence is starting earlier and earlier, and it looks incredibly different. Teen dating violence can look like bullying. It can look like name calling. It can just look like, rowdy, rambunctious kids out in the street. And the fact that this mom was able to notice some of those red flags in her kid and was able to speak to someone who she trusted and felt like could help her was enabled that mom to be able to talk to her daughter, and the daughter actually did disclose that she had some concerns in her relationship. So the statistic that you hear is not necessarily about IPV, but it certainly sheds light on the overlap of IPV and sexual health. Now having gone over IPV, children and teens, we have the pleasure of having one of our very own champions share with you how this all fits and works in the healthcare setting.
Thanks so much, India, for so clearly framing why this is a pediatric healthcare issue. And next, it's my pleasure to introduce Dr. Murray, who will talk about how healthcare providers incorporate IPV screening into their practice. And I know we've had a couple of questions come in so far about how to integrate screening into practice and about screening rates. And Ashlee will be talking a little bit more about that today as well.
All right. Now that we have built a case for identifying IPV in our pediatric caregivers, let's shift gears and talk about the elephant in the room. It's obvious that we all care about our patients and recognize the huge impact IPV has on our children, families, and communities. Yet, there are still numerous barriers and challenges that exist, many of which you guys have commented on prior to this webinar. These barriers often prevent us from successfully screening for IPV and intervening appropriately when uncovered. This slide just has a few of the challenges or barriers that many providers feel. Some of the most common are listed. There is still some perception in our healthcare setting that IPV has little direct impact on the pediatric patient. But I think after India and Marcella spoke, you agree that it indeed does have an impact. Lack of training for all medical providers, including physicians, nurses, hospital staff, social workers, doesn't necessarily exist everywhere. Even though IPV impacts patients across all specialties, most medical schools, nursing schools, residency programs spend none, if little, time training their healthcare professionals. Therefore, because of lack of training, many providers have lack of confidence in themselves on how to screen, what to do when they screen, and what do they do with a positive screen. Often providers feel that if they ask and someone says yes, then they're opening Pandora's box. Then what do we do about the logistical aspects of the screen? We know there are practical barriers that exist to screening. For example, there are overcrowded rooms, especially in the emergency department. There are time constraints on all of us in medicine. There are logistics on when to screen, who to screen, where to screen, what do we do with the screen, how do we document the screen. In addition, there are significant concerns in our patients and our families about the confidentiality of the caregiver when it comes to uncovering IPV in a family and how that may impact that survivor and their children. What about the laws regarding mandatory reporting? I get asked this a lot. What about concerns for child abuse? What about documentation concerns? How do we document our findings? Because we know in medicine we like to document everything. Specifically in pediatrics, how do we protect the patient as well as the family? What do we do with these real-life issues? Last but not least, what about the children? They are usually in the room when caregivers are being screened. And as many of us parents know, they see and hear everything. So I'm going to talk you through some of the solutions that we at CHOP here with the collaboration with our community partners, Lutheran Settlement House, have come up with to help solve some of these barriers and challenges. First, regular mandatory education, first and foremost, must catch up everyone to speed on the basics of IPV. This way, there is a minimum educational awareness and understanding that exists in your healthcare setting. It must be supported by your key departmental stakeholders in order to implement and make mandatory. It should be creative and specific to your healthcare setting. For example, our institution has lots of providers, hundreds of different providers, just in our emergency department alone. Therefore, we've created an online learning tutorial, which is mandatory for all of our providers to complete. It takes about 10 to 15 minutes with a few questions at the end. This is how we originally introduced our IPV program at CHOP. Second, education must be regular and ongoing to keep people abreast of the issue, as well as what you're doing. Providers in medicine like feedback. They like to know that what they're doing and how they're impacting their patients. So it's important that this feedback is provided on a regular basis. In addition, other educational initiatives that we have developed in our institution have included yearly IPV Awareness Month, hospital-wide events, hospital-wide grand rounds that focus on IPV and child abuse. We've also implemented IPV into a longitudinal residency curriculum. We have bi-yearly departmental updates. We also have regular provider emails. And in some of these emails, we also have individual provider feedback on case consultations or referrals that were made to our program. As well as regular mandatory education, it's also important to have readily available resources and support. If you're going to screen for IPV, then you need to have a very clear plan in place for the providers to know what to do if they encounter a positive screen. This will mean different things for different institutions and healthcare settings. No matter what, this plan must have readily available resources and support that anyone can easily access. Here at CHOP, we have a full-time on-site IPV specialist that can be easily called upon when needed. We recognize that this is not possible everywhere, so it's important that referral resources are readily available to provide to victims when they disclose IPV, if they want. Other examples include printable resource sheets, internet or intranet sites, organized resources, visibly present IPV champions within your department, posters that are trauma-informed and family-focused, screensavers, and even possibly commercials on your TVs. Moving on, it's important that we have a cultural change. Establish an environment where IPV screening is universal and expected. Probably one of the most important solutions is one of the hardest and entails a cultural shift many times in our healthcare setting. By making IPV screening routine and universal, it establishes the expectation that screening will occur at each and every visit. There was a question earlier about when to screen in primary care sites. We've taken it on in our institution, in the emergency department, that every time a patient or family comes in, they will be screened for IPV, if it is safe to screen. I have encountered many families where this is their third or fourth time that they've been screened, and they expect it. And as making it routine, it becomes part of the culture, and you are not surprised when you get the screen and no longer feel that you were isolated and given the screen on purpose. There must be a team approach that includes unusual partnerships, such in our department. We have an encounter partnership with the security department, radiology, and even our child life specialists. Lastly, there must be family-centered awareness and referral resources that are available for the families to seek out on their own. The screen must be fast and easy. Lots of questions about how to screen, which I'll talk to on the next slide. It is crucial that the screening process is easy and fast, as well as sensitive and specific. We have suggested using a nonverbal screen that is easy to administer and effortlessly incorporated into the provider's work, which I will talk about further. Next, caregiver confidentiality is imperative to the success of a screen. In Pennsylvania and New Jersey, specifically, there are no laws mandating reporting of domestic violence or exposure to domestic violence in children. It's important that you know the laws in your state. Despite some individuals' strong personal opinions on this, just because a caregiver discloses that they are a victim or their child is exposed to domestic violence does not require a report to DHS. This is imperative to maintain the trust of the victim's disclosure. Any breach in confidentiality of the disclosure could present real harm to that victim and their family. And last but not least, safe documentation procedures. It is never right to document IPV in a child's chart. Legally, both caregivers have access to that child's medical records, and once again, if the perpetrator gains access to such documentation, this could pose potential harm. Therefore, we have come up with some creative ways to document yet still protect that child and caregiver. So let's talk about screening. I'm sure many of you have been in a situation where you're at your doctor's and someone asks you, do you feel safe at home? What does that mean? Do I have smoke detectors? Is there mold growing in my home? Am I being abused? These questions sometimes can be hard to ask as well as answer. If you're going to directly screen your patients or your caregivers, you should avoid questions like, are you being abused or do you feel safe at home? And ask better questions that are more specific, such as, has anyone ever hit, kicked, or pushed you? What does it look like when you argue? Have you ever been afraid of your partner? What is good and not so good about your relationship? However, as you can tell, sometimes this is hard to ask these questions. You may not have a strong relationship with your caregiver or your patient. So we're going to talk about some ways that makes it easier for providers to screen. So instead of a verbal screen at CHOP, specifically we have developed this nonverbal screen. This is rolled out in our emergency department about 1.5 years ago, and now is incorporated into the routine care of all of our patients and families. This screen was developed by our Intimate Partner Violence Task Force at CHOP. It reads at a 5th to 6th grade reading level and includes 6 of the most common types of IPV. It is a purple laminated cardstock that is located in all of our family ED rooms and is available for all of our providers to easily give to our families. We have found that providers, if they don't have to ask the hard questions directly, they have more confidence with screening and will screen more. In addition, on a regular basis, we have screened caregivers who applaud the development of such a screen and express their satisfaction with this type of screen. You'll see the screen on your screen, and the way it looks at the top, it tells the family that at CHOP, we provide this screen for all of our families. You'll see the questions that are listed there. What I want to draw your attention to is at the bottom of the screen, it says, if you answered yes to any of these questions and would like support today, we can help. Simply tell me yes or no, and I will connect you with a person that can help you. The screen doesn't ask you if you're a victim of IPV. It says, do you want help? We recognize there are many caregivers that will be victims and are not yet ready to disclose. That's okay. We're hoping that as caregivers get asked to screen on a routine basis, at some point during their child's care with us at CHOP, they will disclose and seek out help. After implementation of the nonverbal screening process, a quality improvement initiative was begun to see how our screening was going. Ongoing feedback with the screen's implementation have allowed us to make necessary changes over time to improve how we screen. I'll talk about some of those ideas further. Currently, this screen on these cards is administered by the emergency department admit nurse upon room placement. It is not part of the triage process because we recognize the triage process can often be very stressful. It is now routine care to administer this screening card to the patient's caregiver while they are being settled into the room. So as the nurse hooks up the patient to the monitor, gets their vitals, asks them if they want something to drink, gets them a blanket, they hand the screening card to the caregiver. And they ask them to take 30 to 60 seconds to read the card. That's really how long it takes, 30 to 60 seconds. And they can do it while they're doing something else, which allows the provider to feel that they're multitasking, getting things done at the same time. If there is a positive screen and they want a referral, then it takes about 10 to 30 more seconds to actually document the referral, which I'll go through. So all in all, this screen can be accomplished in easy as 1 minute. So let's talk a little bit about the documentation process. So different hospitals use different electronic medical records. Here at CHOP, we use Epic, and in Epic, there are options to add screening tabs. We've created a screening tab located under the nursing narrator, and you'll see the first screen is our BHS, or behavioral health screening for our adolescents. We've titled our IPV the home environment screen. We've taken the words IPV or domestic violence out of the chart, so if a perpetrator does get access to the chart, they're not really sure what that means. Home environment screen can mean lots of different things. The screen documentation goes as follows. As you hand them the card, if they're able to complete the screen and the screen is positive, the provider is asked to complete the referral form, which is linked there. If they're unable to complete the screen, so they select no or they defer the screen, then a tab pops down that asks you why you were unable to complete the screen. We collect this information mostly for quality improvement reasons to see why people are deferring to screen. For example, if there are multiple caregivers present, when we train our providers, we want them to recognize that you should not screen if there is more than one caregiver present, only if there's a single caregiver present. In addition, if the child is too sick to be screened, we recognize that is not the time or place to screen. If there's a language barrier, right now our screen is in English and Spanish. The front is English, the back is Spanish, so which actually captures a majority of our patients. However, right now we are in the phase of developing 8 additional screening cards, 8 additional common languages that our patients and families speak. So all in all, we will have the 10 most common languages on our screening cards within the next few months, which hopefully will incorporate most of our families. In addition, if there is no caregiver present, they should not be screening the patient themselves. And last but not least, we have a tab for other if there's a reason that we did not think of which they did not screen. For example, the parent is incoherent, or there's other issues with the visit. We can collect this information and provide individual provider feedback on reasons for not screening. As you can see, this is a safe way of documenting that the screen was done, why it wasn't done, but then does not have anything in the chart about IPV. If the screen is positive and the caregiver wants resources, we have 2 ways of accessing what we call a referral form. It is listed on all of our computer websites called IPV Council Referral Form. It's easily clicked to. Anyone has access to it. If you click on this referral form, it takes you to an external database called REDCap, which some of you may be familiar with. We use this because it allows us to protect this information from actually the electronic medical record. There's no documentation in that child's record. However, once this referral form is complete, there's an automatic email that is sent to our medical advocates. The medical advocates get this email and are able to quickly respond to that referral. The referral form is only filled out if there's a positive screen and that provider would like support. The questions, as you can see on your screen, are the questions that are asked to be filled out. Who screens, what their role is, their location, the patient's MRN number, and then there are 2 important questions that the referral form asks. One, is this an emergency referral? And it gives you the definition. This means that the caregiver parent is at immediate harm and needs a safety plan prior to discharge. We do encounter emergency referrals occasionally. If an emergency referral is encountered, the instructions pop up that tell you what to do. They should immediately call the on-call social worker. It gives you the phone number. And then also they should page the counselor as well if it's during the hours that the counselor is present. So this is an example of how I said resources and what to do should be easily available. You shouldn't have to fumble your way to find the number of how to get a hold of the counselor when you encounter this in your screening process. But let's say it's after hours, or you do not need an emergency referral, but somebody wants to follow up. This is probably the most common type of referral that we encounter. If the provider selects a follow-up referral, which it tells you what that means, this means that the caregiver parent is safe to be discharged, and the counselor will follow up with them within 24 to 72 hours, depending on the day of the week. The provider then asks several questions: the client's name, their phone number, when it's best time to call, and then some safety questions that are really important. Is this a shared cell line or landline? If someone answers, is it okay to tell them they're calling from CHOP? Is it safe to leave a voicemail, etc.? And then lastly, you'll notice there's a resource list that is easily available that you can print out and give to your caregivers. This list has resources not only for domestic violence, but other important non-domestic violence related resources in the Philadelphia community, such as shelters, mental health, etc. And then lastly, on that referral form, oftentimes our providers want to know that if they make a referral form, something is being done. So our medical advocates will then reach out to the provider telling them that contact has been made with the client. And then oftentimes the providers feel that they've done something good and will continue to screen. So I wanted to highlight some of the key points from our screening and documentation process. so far. Some of these I've addressed. These are the key points that when we do our training with our providers in the emergency department as well as the rest of the hospital, that we focus on these. Most importantly, you only screen the caregiver when he or she is alone. We teach our providers to screen anyone and everyone, no matter what they look like, no matter what color their skin, male or female, young or old. They should be screened if they are alone with their children. We also train our providers to never actually discuss IPV in front of a child that's older than 2. Many times as a physician, if somebody discloses to me, they want to start talking about it and they want to share their stories, and then you want to ask more questions. This is the time where you take a pause and you want to make sure that if a child is developmentally 2 or older, that they should be separated from the room, which is why we partner with our child life specialists to help make this happen in certain situations. In addition, we never want to document IPV in the child's chart. I emphasized this earlier, but it's important that during training that you emphasize this. We often have providers that get excited when they uncover or someone discloses because they want to help them, and then they'll document them in the chart. Part of our quality improvement initiative, I often do, I look at charts that they're screened and make sure and give feedback to providers if documentation happens to happen in the chart. Providers are asked to complete that referral form for all positive screens. At the beginning, we had them filling out the referral form for all screens and realized that this was too time-consuming. So to help streamline the process and make it faster, it only happens for positive screens. We want our providers to know that they can still call social work and should call social work for all emergency referrals. That way social work is involved because a lot of times it's the partnership between the IPV specialist and the social work that is best for that patient and family. They should contact the IPV specialist for all referrals during the day and then send a referral to them after hours or on the weekends. So I think it's important to highlight this slide as some of the interventions that our specialists provide. A lot of times as a physician, we make a referral, we don't really know what happens, and we think it's a one-time interaction. I think what a lot of providers don't recognize is this is an ongoing relationship that the specialist creates with the client and the family. These are just a few of the many interventions that is provided by the medical advocates of LSH. A lot of times as a provider, if we give this feedback to the departments and the providers that these are the things that we can offer, they want to screen more and they want to have more referrals so they can provide more of these resources for our family. They get excited when they hear about all the amazing things that can happen. So I wanted to take some time now to talk about screening rates. We had a question earlier about what our screening rates are at CHOP and what have we done to address any drops in screening rates and how we can improve our screening rates. These slides are specific to the emergency department. In the past year, year and a half, we've just started tracking our screening rates in the emergency department with the goal to expand this ability throughout the entire hospital as well as our outpatient sites. So we recognize that our screening rates may not be the same throughout the rest of the hospital. Prior to the implementation of the QI project, you'll notice that our screening rates were about 1 to 2%. We see almost 100,000 patients and families a year in our emergency department, which means we are missing 98% of potential family violence cases. One of the important things that led to this improvement in our quality improvement process was the implementation of the screening and documentation practices that I've previously discussed. The laminated screening card, making it easily accessible, the documentation process, making it a hard stop in all the charts. That way there's a reminder for all providers or for the nursing providers when they admit the patient to screen. Our goal was initially 30 to 40%, and as you see, since November, after making these changes, we've kept our screening rates above 30 to 40%. We chose this number because we know a lot of our patients come into the emergency department with 2 caregivers. Unfortunately, we will miss those caregivers, but hopefully at a future visit, if they're alone, we're able to screen them. We also recognize there are some patient families that can't be screened for the other reasons that I previously discussed. We hope over time that we'll be able to get feedback from our quality improvement initiative and increase these screening rates even more. One of the other things that we track is documentation. As you see here, where it's important that we screen, but that we also document appropriately. So even if you aren't able to screen, there should be a reason why that you weren't able to screen should be documented in the chart. So we're about 60% documentation rate of why or why not we screened. Our goal is 100%. So we have some room to make, but notice that we've made significant improvements with this new documentation procedure. Another important measure is the number of providers that are actually completing the screens. You don't want the same 12 people doing all your screening. And so one of the important things with this QI process is our training, and that's why it's imperative with our community partners that all of our providers get trained on a regular basis. As more providers get trained, there are more champions that feel comfortable with this process and will disseminate that knowledge to the rest of the department. Since these new training procedures and documentation in November, you notice on average we have about 150 different providers screening each month. 150 different providers. That means it's just not the same person screening over and over again, which is really awesome. And then last but not least, one of the other data points that we are collecting is why we're not screening, because this is the important information that we can take back and make changes and improvements to our screening process. So you'll notice if a screen was deferred or they selected no, they have the option of listing a reason why. Emotional stress of a caregiver you'll see listed there due to the severity of the illness. Some of these reasons we can't do anything about, and that's okay. Other reasons we can collate and provide individual feedback. So this slide highlights some of the results of our program since implementation of these changes. In the past year and a half, we've trained over 300 providers in the emergency department alone. And since November, we've screened over 20,000 families. Our referrals to date, and this is as of last week since we've made these changes, has been 183. Last but not least, I wanted to highlight some of the lessons learned from this experience. We started out as a small task force of about 10 to 12 members. We learned that as we incorporated these changes, it was important to move to universal intervention. It was important to expand this special interest group to have champions throughout the hospital and unexpected relationships. We have relationships with child life, social work, we have physicians, nurses. We also have interest from PR, security, and we even have a lawyer who's part of our task force now. So it's super exciting. The more you spread this information, the more people will join. It's important that you train a core group of champions and that training accommodates the availability of the staff members. Most of us in the emergency department have shift work, and therefore it's important to create training that's specific to where you work, that happens day or night. And we've used some of these strategies to help disseminate the training to everyone and not just people that work during the day. I think it's also important not to underestimate what this issue means to some people. As I talked more and more about this with providers, I hear more personal stories about their experiences with IPV. Use that emotion to empower them to screen and to teach other people how to screen. Last but not least, this is probably the most important lesson learned. Take the time to get honest feedback. Throughout our QI process, we've done what are called go-and-sees, where we go and watch how the screening is happening. We get real-time feedback of the screening process from the people that are actually doing it. We take that feedback, we respond and revise, and then we reconnect. We send out emails, we talk with those providers, we take that feedback and make things better. That way they feel their voice is being listened, and they're going to be more likely to screen in the future. So what are some of the essential ingredients for you where you work to make screening and documentation part of your practice? Staffing. Had mentioned before, you want readily available resources and support. That's going to look different depending on where you work. You may not be able to have someone on site, but as long as you have those resources available for your providers who end up screening. Finally, you want to have administrative and strong leadership. There's a lot of administrative work when it comes to developing this process, not only from printing and laminating all of our screening cards, but to organizing our training sessions. You want to create a relationship with a strong leadership in your department that's going to support your efforts, and this has been imperative to our success at CHOP. It's important to monitor the process and the outcome measures to make sure what you're doing has an impact. From a system standpoint, you want to have support from the high and mid-level administration to help make things happen. And then it's important to start with clinical champions in different disciplines, as we discussed earlier. Finally, you want to make the process meaningful and easy to accomplish. We often share client stories with our providers in the department to show them the impact that they're having and making the process meaningful for them.
Thank you so much, Ashlee. It's always really great for us to be able to share from one provider to other providers kind of how this really feels, because as the domestic violence advocates in this equation, India and I are always so excited when we get to work with the patient, but we recognize, or caregiver, but we recognize that there's a lot of work that happens to make that connection work. So I hope that that was helpful in addressing some of the barriers for folks. So we're really big on kind of takeaways, and before we go over some of the questions that came through, which we definitely want to cover, we wanted to just share some suggestions that we have. If hearing the webinar today kind of made you think that you are interested in kind of being part of bringing this type of IPV advocacy awareness or intervention to your medical site or workplace. And so first step, which, as a domestic violence provider, we're biased, but we really encourage you as your first step to develop and nurture contacts with your local domestic violence program. And that's something that we would love to support people with. We are part of the Pennsylvania Coalition Against Domestic Violence, and so we have very warm relationships with domestic violence providers throughout the state, and even at that state level, they can help us get connected with folks outside of the state. And so we would love to be kind of the facilitator for developing those relationships. A lot of domestic violence programs in Pennsylvania also do receive a little bit of funding to allow them to do medical advocacy services, at least some basic training. And a lot of us are really interested in developing those partnerships with you guys. So we are more than willing to help you get connected with the domestic violence provider that makes sense for your site. Next, and this is really based on the steps that we've been able to take to start our program in all of our different sites, is identifying and bringing together stakeholders who we call our champions. And as Ashlee said, it's really helpful to have a mix of folks for that. Folks who are from the clinical side, we often have folks from social work who are interested, and also people who are at the administrative level and the leadership level, so that you can really develop some of that larger level buy-in. And honestly, initially, a lot of the planning looks like bringing those folks together with a box of Joe from the coffee shop and just like talking about how we can make this work in this setting. We know that all it takes is a few motivated people in any medical site to get this off the ground. Next is training, awareness raising, and education. So this is kind of the actual infrastructure of how do we even start to increase awareness and intervention around this at our site. From there, from the information gathering that we get through that step 3, we usually institute screening, documentation, and referral processes. And then ultimately, together, we're able to improve patient, family, and community safety. So I know those are really broad steps. And again, I want to just reiterate that this process looks different in every site, and we have learned to be flexible with the different cultures and needs of the medical sites that we work with. And so we really want to partner with you to try to make this happen everywhere.
Thanks so much, Marcella. We've had a flurry of questions come in, so I'll try to direct them to different folks on our team here today. But Marcella, for you, one of the questions that just came in was regarding, I think, a slide you presented at the beginning, which showed a drop-off in referrals at when the funding stopped for the program. And the question was whether that was specific to CHOP or was that in a different healthcare setting?
Yeah, thanks for asking. That was actually at St. Christopher's Hospital, which is our longest standing program, and that's really why the drop in referrals was so marked, because we had developed such a strong partnership there over the nearly 10 years that we had been there, and we just noticed that physical presence, the lack of that really negatively affected our rate of screening and referral. Yep.
Thanks. Another question that came in was regarding the referrals and type of assistance that the medical advocates provide to families, including referrals to TANF or food supplement programs.
Hi. Yeah, so I definitely want to talk a little bit about that. That slide had a lot of different information on it, and I wish we had time to talk about all of the different fabulous resources that we support people with. That slide specifically references TANF, or cash assistance through welfare. And the reason that we include that is obviously we can support clients in navigating lots of different resource needs. Specific to cash assistance and other welfare benefits, we actually assist clients in completing a waiver that exists for intimate partner violence survivors that excludes them from a lot of the requirements that prevent survivors from accessing resources that they really need and are eligible for. And so oftentimes we hear from clients, and this is why the law was established and that waiver was established, that survivors who are experiencing economic abuse or trying to separate from their partner, if they are legally married to that partner, they need to document that partner's income also when they're applying for assistance. And if they're not actually able to, if it's not a financially safe relationship where they are actually sharing finances, it's not a realistic reflection of that client's needs. And so the waiver prevents a client from having to disclose their spouse's income information, and it also excludes them from requirements about having identification and other documents if they're fleeing an abusive relationship, because we know that so often folks have to leave out the door with whatever they have in their pockets. And so that's why we specifically referenced TANF, because that's often a resource that our clients and even our provider partners are not aware of.
Another slew of questions have come in, or recognition of the value of the medical record in doing this, an electronic medical record. And at CHOP, it presents both barriers and challenges, as our team has shared today, but we have been able to figure out how to use the EMR to our benefit in making this screening feasible and reasonable for providers. But one question came in about whether the referral form that's available in EPIC that Ashlee showed is available to those outside the ED in the ambulatory settings.
So the referral form is through REDCap, can be used and accessed at CHOP. Specifically, you can access it through what is called a dot phrase. It's called .IPV screen. So if you are in a provider note or social work note, type .IPV screen, the screen will come up, and then within that screen there's a link to the referral form, and that should be accessible to all providers within the CHOP network. If it is not, you can let us know. But we have made it so that if you're in the ambulatory site or the inpatient site, if you want to have access to that screen. If you forget the dot phrase, there are ways of incorporating the screening tab from the REDCap form into your EPIC bar at the top. This is something that we are exploring with our IT department to add this to the inpatient site as well. But in order to add this, we have to have training, and that process is still in the works, especially with the inpatient screening process.
A question that came in early on that we want to make sure we address goes back to caregiver confidentiality and how it's explained to parents. Many parents may assume that disclosure could trigger a child abuse or child service involvement. And I know in some of the pre-questions we received, or identification of barriers, folks also talked about parents' distrust of social workers and fear of child service involvement. India, I wondered if you could speak a little bit about parent confidentiality.
Sure, and that's actually a really great question. We come into contact with that question a lot, whether it be from providers or parents themselves. So our advocates, we pride ourselves in being incredibly transparent with our clients by letting them know as early on as introducing them to us, letting them know our names, what our obligations are, and what our confidentiality looks like. So early on in the conversation or in the intervention with a client, we let them know that everything that we talk about is confidential, except we let them know that we, like the providers and social workers at the hospital there we're meeting with them at, are mandated reporters, so are we. And we explain that to them in a way that gives them the option to disclose as much or as little as they want. So that looks like oftentimes, hi, my name is India. It's really great meeting you. I just want to let you know before we get into anything that everything you and I talk about is confidential. However, because we know that domestic violence and child abuse oftentimes co-occur, if you mention anything about threats to a child or any form of child abuse, I will have to notify Childline about that. And I like to tell people that early on so you don't feel trapped or blindsided during our conversation when I have to interrupt you and stop you to tell you that I have to make a report. And oftentimes folks are really appreciative of that and say, thank you for letting me know. They'll either say, no, I don't have anything to report. I feel like my child is pretty safe, or you'll see something in their head go off and they're like, I think I'm going to be careful navigating this conversation right now. So I hope that answers your question.
Thanks. We've had a few questions come in as well about folks who are interested in becoming champions in their area, their clinical area, and what that would include. I'm not sure who might want to speak to that, or how we've established champions in our clinical areas at CHOP so far.
So we always welcome the idea of folks being champions at their site, whether they have an official partnership with Lutheran Settlement House or not. At the base of it all, if a person wanted to become a champion at their site, this could happen by way of an email from myself or Marcella or any of the other medical advocates, and we'll just set up a conversation or a meeting just to talk about what are your goals, what are some of your needs, what have been some of the feedback expressed from the patients or the caregivers at your site, and figure out how to help you brainstorm how to execute those goals. If folks feel like they want something a little bit more intensive, maybe having a Stop IPV program there, then we'll set up a different kind of meeting to talk about how that will look. In general, for anyone, Philadelphia has been working together in a citywide effort to respond to IPV in the medical setting and in the behavioral health setting. And that looks like a group called the Shared Safety Group, and we have many different subcommittees. I, for instance, sit on the subcommittee for entry and access, which means how are we meeting people at the door of these health centers to be able to identify and address IPV. At the moment, we don't have open enrollment, but we just revamped the Shared Safety. We just created a new name and are rebranding ourselves, and once things become a little bit more settled, emails will come out. So as you're listening to this, if you are someone who's interested in joining Shared Safety, I encourage you to drop your email in the comment box. I will jot it down and be able to share it with our Shared Safety folks, so when open enrollment starts back up, you guys will be notified.
Great, thanks, India. We've also had some questions come in about reporting to Child Protective Services for children who are living in the home with domestic or intimate partner violence.
This is probably one of the most common questions that we get, especially from the provider standpoint. When a family discloses IPV, you feel protective of the child, especially as a pediatrician. I know I feel that way. And it's important to know your individual state laws. Not all states have the same. Specifically in Pennsylvania and New Jersey, as I mentioned earlier, there is no mandatory reporting for child exposure to DV. Each state is different, so it's important to understand that. But just because somebody discloses that they live in a home with DV, it is not required to report. And you should not report. There are lots of reasons why, which we don't have time to get into today, but you should not automatically report just because of exposure to DV, only if there are concerns for child abuse themselves.
Thanks, Ashlee. We had a question come in about healthcare providers who may see children's chronic conditions that are either exacerbated, such as asthma flares that might be exacerbated by exposure to IPV. And what sorts of resources healthcare providers or things healthcare providers can do to help the patient and the parent deal with that trauma and respond to it appropriately.
Hi, this is Marcella. I appreciate you bringing that up because it really does underline kind of the real life impact of all of the kind of ACEs research that we discussed as far as kind of how this actually looks like as far as health impacts on children. This is definitely an area that the domestic violence service providers in our area certainly want to support families with. And so one of the things that is certainly available is the therapy and other services for children who are experiencing their own issues as a result of witnessing intimate partner violence, because we know that even if they haven't been directly impacted, a lot of the things that you're discussing, the research supports, which is that their symptoms can actually mirror the symptoms of a victim themselves who's nervous to go to court or to have an interaction with that abusive partner. And we've had a lot of success. So we recently, as India mentioned, got funding to support trauma-focused cognitive behavioral therapy, TFCBT, for child witnesses of intimate partner violence. We've had a lot of success with that program. As you can imagine, we've had a lot of enrollment. We've only had it in existence for several months now, but there's a lot of need in the city, and we're glad to be able to provide a service for all those families impacted. And so basically a lot of what we do in that service, just to give you a feel for it, is that our trauma therapist really works with the children on kind of linking their emotions with their thoughts and their behaviors, and then developing a trauma narrative that allows them to be able to process in their own age-appropriate way what they have witnessed, and letting them know that what you have witnessed is not normal, but it's also not your fault, and it doesn't make you wrong or bad. And so we've had a lot of success with that. We serve in our program kids ages 14 all the way up to 18 who are experiencing issues as a result of witnessing IPV. Another really kind of logistical support, we're also new to the game of child therapy, and so there's a lot of support available. Children's Crisis Treatment Center, as well as our sister agency, Congresso, also provides services for children witnesses of violence. Logistically, I know that you also asked about kind of supporting them in going to court. And I also want to just do a plug for our other sister agency, Women Against Abuse Legal Center, and they provide court accompaniment and also just legal information and advice for survivors impacted by IPV and their family. And so they're definitely somebody that we always use as a resource, and we encourage clients to use as well, as far as kind of physically having some support right there in court if the child is really nervous about that, rightfully so.
I know you guys talked a bit about providing case consultations to providers who may have questions about how to respond to families. Are there any other services that you provide to hospital staff through the medical advocacy program, or any other ways that this partnership helps those also in the hospital?
Sure. So definitely case consultation is one of the major ways that we interact with staff at our partner hospitals. But another really surprising kind of unintended outcome of our program presence at hospitals is often a lot of staff disclosures. And, you know, that really just comes from, like, when you're creating a safe space for patients and families, you're also creating a safe space for staff. We know that this issue does not discriminate, and it's very common that as a result of starting these conversations, we've had staff say for the first time, you know, I never felt safe in my workplace to tell them that this was happening, but this is happening to me too. And we are often able to serve as kind of that person's door into the domestic violence services workplaces in the city. Just for conflict of interest and just comfort of that staff person, we often will not be their ongoing counselor, but what we can certainly do is be that first point of contact. And so oftentimes we'll have staff come to the office of the advocate and just sometimes even under the guise of referring a client, and then they shut the door and they just say, listen, like, I'm so glad you're here. This is the first time I've ever told anybody. And one of the benefits to that is that, you know, from a workplace perspective, we've also worked with the HR departments and the security departments at our different sites, because there's a lot of things that workplaces can do to make it safer for survivors. And so oftentimes we've supported with our partner hospitals in changing someone's shift as part of their safety plan, or even changing their location where they work as part of their safety plan. And we've facilitated those conversations in ways that the staff person was not empowered to do before. We also just try to make sure that all of our hospital kind of HR departments and employee assistance programs are kind of up to date as far as legal requirements, as far as, you know, for example, Philadelphia has required unpaid leave for domestic violence, 120 days unpaid as part of the Philadelphia ordinance. And those are things that folks just don't know about, and really well-meaning employers also don't know about. And so we try to make sure that from the kind of systems level for employees, that all of our hospitals are equipped to respond to employee disclosures as well, because it definitely does happen. It's definitely an unintended outcome of the program, but we're always excited to get survivors connected with services. Additionally, we kind of work in our general outreach and awareness raising and with our task forces. So every month at each of our hospitals, we have some type of outreach or awareness event, and we target different departments or different settings. And so from the kind of staff level, we just try to create kind of a consistent presence and reminder about the issue.
I think we had one last question come in, and so today we've been focusing on our efforts in the pediatric healthcare institution, but I think there was a question that came in around the importance of this work and ways to start this work in the community behavioral health and other youth and family serving systems, and opportunities for partnerships therein. Good afternoon. I want to thank you for taking the time from your busy schedules to join us for today's webinar entitled "The Parent is Your Patient Too: Making the Case for Intimate Partner Violence Advocacy in the Pediatric Healthcare Setting." If you're a physician, nurse, or social worker joining us today, there is an opportunity to gain credit for this webinar. Additional information regarding continuing education units was provided in the reminder email sent from WebEx at 10 a.m. this morning. If you're eligible to receive these credits, please make sure to complete the online survey that will pop up when we end the webinar today. None of the presenters have anything to disclose. If you have questions or experience any difficulties in obtaining your continuing education, please send an email to Kim Sloth at the email listed here. This webinar is being hosted by the Violence Prevention Initiative at the Children's Hospital of Philadelphia. And my name is Rachel Myers. I'm a research scientist within the Center for Injury Research and Prevention here at CHOP. The goal for today's webinar is to address the issue of intimate partner violence within the pediatric healthcare setting. And there's several objectives for today's webinar. First, to recognize research links between intimate partner violence, or IPV, and public and pediatric health. To be able to list barriers to providing IPV medical advocacy in the pediatric and medical setting. To identify strategies for successfully integrating IPV into most medical settings. And to create action steps for partnering with participants' local pediatric healthcare providers. Healthcare providers serve as important partners and also trusted sources of information as parents navigate the joys and challenges of raising healthy children. While intimate partner or domestic violence is commonly thought of as a private personal matter, we know that all too often children witness such violence in their homes, as recent national data suggests that more than 1 in 4 youth and adolescents report having witnessed violence between their caregivers. Supporting parents in accessing resources and enhancing safety for the entire family is one way that healthcare providers can begin to address this exposure and prevent adverse outcomes. Implementing routine inquiry regarding IPV among caregivers of our patients is an important way in which pediatric healthcare institutions can work to overcome stigma related to IPV and to support families in accessing the right resources at the right time. However, such screening in the pediatric setting is not without its challenges. The sensitive and confidential nature of IPV disclosure, discomfort among providers in responding to such disclosures, and limited knowledge of available resources all may present barriers in clinical practice. Through our exciting partnership with Lutheran Settlement House and their Stop IPV program, about which you will soon learn more, we have established a strong partnership that has overcome these barriers and allowed us to establish and enhance our institution's efforts to address IPV as a pediatric healthcare institution. Before I introduce our speakers today, I'd like to address a few housekeeping items with you. First, if you're having any technical difficulties, please double check your confirmation emails. The latest one was sent around 10 a.m. this morning. In the emails, you will find links to join the meeting and to download WebEx Event Manager for first-time users. You should hear the audio through your computer speakers. There's not a call-in phone number available for audio. At this point, we will not be able to help you with technical issues. If you have questions for the presenters as we go along today, and we do encourage your questions, please type them into the chat text box at the bottom of your screen and direct them to our host, Lindsay Mitros. There will be opportunities to ask questions throughout the presentation, and we'll save time at the end today for questions and answers as well. Because of the large group joining us, it's not possible to open up the lines for audio or verbal questions. Also, other participants will not be able to view the questions or comments you submit. From previous webinar feedback, we've learned that this can be distracting for participants. And lastly, this webinar is being recorded and will be posted on our website, chop.edu/violence, within the next week. So today's participants, we have close to over 100 people registered for today's webinar, speaking to the interest and concern in addressing the problem of intimate partner violence among families. Among our participants, we see people from many disciplines, including medicine, nursing, social work, health administration, education, and health educators, as well as many locations across the country, Texas, Vermont, Virginia, Louisiana, and Wisconsin. If we're not describing your role or location, please text us in the chat text box and let us know. So now it is time to introduce our speakers. So today, joining us will be Dr. Ashlee Murray, an attending physician in the emergency department here at CHOP and a fellow of CHOP's Violence Prevention Initiative. Marcella Nyachogo is the Assistant Director of the Bilingual Domestic Violence Program at Lutheran Settlement House. Lutheran Settlement House is a nonprofit, community-based organization committed to serving children, adults, and families living in Philadelphia. India Azzinaro is a medical advocacy supervisor at Lutheran Settlement House and at CHOP, and she's also a fellow of our Violence Prevention Initiative here. And so without further ado, I will turn the mic over to India.
Good afternoon, everybody. I want to thank Rachel and all of our CHOP friends for helping us host and facilitate this webinar. We're all really excited. And also echo her welcome to our webinar titled The Parent is Your Patient Too. We're so honored that you all have taken your lunchtime to be with us this afternoon. I'm particularly excited to be one of your facilitators because I'm coming to you as an advocate on behalf of parents in the pediatric setting. I've had firsthand experience mending the fences, encouraging folks to see IPV as a pediatric issue, and offering providers and professionals the resources that they need or ask for to help navigate in between the two worlds. You have two pictures in front of you. I like to offer up folks a visual of what our team looks like. We're bright, bubbly, and fun. The photo you have to your right is of our current team at the moment with our partners, with our advocates who are providing support to our Philadelphia partners. From left to right, we have our advocate, Anna, who's providing support to Einstein. Then we have Julia, who's at St. Chris, myself, who's in the middle, Ashlee, next to me, who's providing support to CareBots, Jessica, who's at CHOP Maine, and lastly, Akia, who's providing support to ARIA Frankfurt and Torresdale hospitals. Now that I've given the briefest introduction ever,